I'm going to go ahead and introduce all four of the speakers, and then they'll remind you of who they are as they come up. So the order that you will hear them coming up will be the order that I introduced them here this morning. So our first speaker is named Mike Gnaciski. He attended and graduated in 2007 from the University of Wisconsin-Eau Claire, majoring in athletic training. During his time at Eau Claire, he had interned with the Claire Express baseball team of the Northwoods League, as well as the Minnesota Twins organization. He moved back towards Milwaukee after undergrad to pursue a master's degree at Concordia University of Wisconsin, focusing on rehabilitation science. Served as a graduate assistant athletic trainer at Concordia for 2 years, working with tennis, wrestling, hockey, and baseball, and working at a local high school his second year. After grad school, he was awarded the Athletic Training Fellowship at Stedman Hawking Clinic in Vail, Colorado. Once he completed the fellowship, he was asked to stay on with the clinic as a physician extender and assistant athletic trainer fellowship coordinator. He currently works with Dr. William Sterrett, who has been one of the largest supporters of athletic trainers who serve as physician extenders. Our second speaker will be Grante Norte. Grant received his bachelor's degree in exercise science and sports medicine from California Lutheran University. He received his master's degree in education from the University of Virginia, and he conducted an athletic training fellowship at the Stedman Clinic in Vail, Colorado. He is currently the head athletic trainer at the State University of New York, and he is an active member of the NATA, NSCA, NDCOT, and he's a guest reviewer for Sports Health in the Journal of Athletic Training. Our third speaker is Angela West. Angela, after finishing the athletic training fellowship at the Stedman Hawking Clinic, accepted a full-time physician extender position with Dr. Millett. She received an undergrad athletic training degree from Washington State University and continued to the University of Connecticut to earn her master's degree in athletic training and exercise science. Her research interests include illnesses related to heat and hydration, as well as shoulder disorders. Angie has served on sports medicine teams at the Boston Marathon, Winter X Games, and the Dew Tour, and continues to provide outreach athletic training in Vail, Colorado. Our fourth speaker is Dr. Peter Millett. Dr. Millett is an orthopedic surgeon and partner at the Stedman Clinic in Vail, Colorado. He specializes in disorders of the shoulder, knee, and elbow, as well as sports-related injuries. Prior to coming to Vail, Dr. Millett held a faculty appointment at Harvard Medical School. He has authored over 90 peer-reviewed articles, numerous book chapters, and 2 books on orthopedics, sports medicine, and shoulder surgery. Please help me in welcoming all 4 speakers. And first at the podium will be Grante Norte. Our first speaker, my mistake, will be Mike.
Thanks a lot, Justin. How's everybody doing today? All right. We're going to start off with a couple questions. If I can get a show of hands, how many of you guys have seated shoulder dislocation? So pretty much most of the room. We'll keep your hands up. How many of you guys have attempted to reduce that shoulder dislocation? So a little bit less. How many, if I can see another show of hands, how many were comfortable in doing so? All right. And how many people immobilized after the injury? All right. So you can see how prevalent of an injury this is with the athletic population that we deal with on a daily basis. We're going to just shed some light on this topic today. Hopefully, to make everybody a little bit more comfortable in dealing with this situation. One last question before I proceed. How many people in the room think it is appropriate for athletic trainers to be reducing shoulder? All right. So overview of what we'll be talking about today. Just general shoulder injuries. We're going to be going over glenohumeral dislocations. We'll talk about the history of dislocations, epidemiology, and problems. Grant will come up and we'll talk about the anatomy and biomechanics. Well, then we'll have Angie come up. She'll go over acute management, recognition of the dislocation, as well as when, where, why, and how to reduce. And then we'll have Dr. Millett come up and he'll go over post-reduction injury care, as well as treatment options. Talking about surgical versus non-surgical options. But just a little bit of history of dislocations, to give you a little video. Knowing that, with the athletic population becoming bigger, stronger, faster, nowadays, these high-velocity sports we must listen to what our athletes say as far as what their chief complaint is. Typically, when they're coming into us for these first three, if they come with a chief complaint of pain, it's usually one of a couple injuries that could be, whether it's an imbalance problem dealing with impingement, if it's an overuse, typically they'll complain of pain for tendonitis or growth problems, or separations would be another indication that they're coming in for pain. If patients come in complaining about weakness, listen to their chief complaint. Typically, it's going to be a tear of the rotator cuff causing that weakness. And then finally, if patients coming in and talking about instability, more likely than not, it's either possible labral tear or a problem with instability as far as dislocation, subluxation. More so of the glenohumeral joint, which we'll be focusing on today. So glenohumeral dislocations, they account for approximately 50% of all dislocation, which is the most common traumatic dislocation. It is the most commonly dislocated bilateral joint in the body, and due to the fact that it is a freely movable joint, it is the most mobile joint in the body. Typically, anterior dislocations account for 90 to 98% of those shoulder dislocations. Subcortical would be most common. You can see in the picture there, we have the common mechanism of injury with Candace Parker with that overhead activity and forced external rotation, which Grant will be going into a little bit later. Going into the history of glenohumeral dislocations, dates back to approximately 3000 BC, when with the Edwin Smith Papyrus, which was an ancient Egyptian medical text. It was based on surgical trauma. And the rationale behind it then was a pretty scientific approach to medicine at that time. Later on in 460 BC, we had Hippocrates, who was known as the father of medicine. He gave us the first true description of glenohumeral instability. He also gave us a brief description of anatomy, classification, conservative treatment, techniques for closed reduction, which at that time included traction and counter traction, and as well as the first surgical treatment, which at that time was considered placing a hot iron into the axillary area to force a muscle retraction. Continuing on a little bit more present day with history of glenohumeral dislocation. In 1861, a man by the name of Flowers described the groove occurring at the posterior lateral shoulder between the head and the greater tubercle. This was later defined to be Hill-Sachs lesion. Then in 1890, Broca and Hartman described the glenoid lift attachment from the glenoid inferior angle. You can see from the studies that we pulled out, the 4 that we have on the bottom there, those that have reported on the incidence of glenohumeral dislocations have had problems with small sample sizes. And you can see from the United States studies that we pulled, the one from 1970 to 79, as well as the one from 2000 to 2006, that incidence rate from 11.2 to 23.9 has nearly doubled over the course of the last 30-plus years. This is more than likely due to a combination of better data collection, as well as people doing those higher impact, higher velocity type sports. So in picking apart that last study, most recently done by Zakili and Owens out of El Paso, Texas, incidence rate of 23.9 per 100,000 person years, found that males are 2.5 times more likely than females to be dislocating. Primary occurrence age is between the ages of 20 to 29 years old. Nearly half of these occur during athletics. And there is a higher incidence in military and athletic populations. And kind of breaking down those populations, what we've been seeing in the high school athletics in studies taken from 2005 to 2007, shoulder dislocations and separations account for 23.7% of all injuries, which is second to just sprains and strains. And then we have the sports kind of listed where these dislocations happen more often. You can see, especially towards the bottom, where those contact sports are the ones where you're going to be really seeing those anterior shoulder dislocations. In pulling some research out from the college setting, the NCAA injury surveillance system from 1988 to 2004 showed again that those high-impact sports for men, hockey, wrestling, football, once again with the highest injury and dislocation rate. Important to know that these percentage are overall shoulder injuries are taken from game situations, which is much higher than practice situations. So some of the epidemiologic concerns. The true epidemiology of traumatic glenohumeral dislocations is still poorly understood, more than likely due to insufficient data collection, and the resources are limited to those injuries presenting to the hospitals and emergency departments. It excludes those seen by PCPs or those who failed to seek medical care. The direction and the nature of those dislocations is not consistently defined as either whether it's an anterior dislocation, inferior or posterior dislocation, nature being whether it's a primary dislocation or a recurrent dislocation. So some of the concerns we deal with when seeing anterior shoulder dislocations primarily are you want to see a timely reduction and you want to minimize the sequelae of the injury. And you want to do as best as a job you can to prevent against recurrent episodes. Secondarily, you got to take into consideration cost and time for the patient, whether or not they'll have an ED visit, whether or not they'll need sedation, and the time of the reduction, the amount of time that's out. Secondarily, also consider the amount of pain that the patient is having and decreasing quality of life for the future. So as athletic trainers, we are commonly the first healthcare provider on site to see the dislocation. We want to set a goal of a safe and timely management. However, right now there's a problem with lack of continuity within the acute management, and there really is no gold standard set right now. So in our research efforts, current research efforts primarily are focusing on the hospital settings, operative intervention, and immobilization. However, there's possibility within literature of the management on acute setting on the field, as well as using the safest and most efficacious reduction techniques. So as far as the consensus on management, the questions are whether or not we should reduce, how many attempts should be given, what method of reduction should be used, where the reduction should take place, what to include in the evaluation, both pre and post a dislocation, how to mobilize after. Right now there's just a lack of education going around, and there's lacking an ATA position statement on that. Purpose of this talk today is just to provide a guideline for healthcare professionals. We want to describe the safest techniques according to current literature, and we also want to establish continuity in the management of the acute anterior glenohumeral dislocation, in turn improving patient orientation.